Hi, everyone, and welcome to the webinar, How the Infection, Prevention, and Control Function and Role Will Change. Donna, can you move the next slide, please? Thank you. Today's discussion will include the state of COVID-19 and emerging IPC program challenges, regulatory mandates and lessons from other sectors, staffing and empowering the IC lead role, modernizing IPC program management, and a Q&A section at the end. Next. Today's panelists are Donna Nucci. She's an RN, has a master's degree as well, and is a certified infection preventionist with over 30 years of nursing experience. She's consulted with around 40 healthcare organizations. She works at Yale New Haven Hospital, on the board of directors at Connecticut Patient Safety Organization, an author, speaker, and recipient of Healthcare Quality Awards. Also on our panel is Raj Shah, the founder of CareSafely. He has 25 years expertise in safety, quality, and compliance. Was past president of Alchemy Systems, and has industry experience in food, manufacturing, technology, retail, and banking, as well as an MBA from Kellogg at Northwestern. Thanks so much for joining us. Raj, want to take it away?
Thanks, Kate. Good morning, folks, or good afternoon, folks, wherever you might be. Just a quick introduction into CareSafely for those of you who may not know much about us. We're a software platform specifically designed for the senior care sector to help them with their quality, safety, and compliance management. We consider infection control to be a core part of course, safety itself, as well as many quality initiatives. And our platform is used by our clients to basically manage their entire safety program and IPC program, including assessing risks, managing the COVID response, managing the administrative time it takes to manage the whole program, identifying high-risk employees as well as facilities, especially if it's multi-facility organizations. So a variety of things, we'll talk a little bit later about them, but just wanted to give you a high-level view of CareSafely. I know you all are here to hear Donna, so we're going to very quickly now take it over, Donna.
Hi, I'm Donna Nucci, infection preventionist, as was introduced, and welcome. I'm going to start off with just sort of giving a little background, our history of pandemics. I know some of you probably have some experience with infection prevention, and for some of you, this is going to be a lot of new information. Those of us who've been doing infection prevention for a long time have a lot of fun reading. Actually, there's a few really interesting books about the history of pandemics. And so if you're kind of a pandemic nerd like myself, this is something that you're really interested in. I just felt like this was kind of an interesting infographic. It sort of puts in line for you. You can see where we are. And I think this is why when you hear some of our public health professionals in the United States speak a little bit about COVID-19 and how they're still nervous, is when we compare COVID-19 to other respiratory pandemics, we're at a very small rate of death. I know we all like to believe that maybe we have, masks are probably just one form of protection, but we do travel much more than they did during some of the other flus. So oftentimes in my circles, we compare it to the Spanish flu, which was in 1918 and 1919, where it killed between 40 and 50 million people. So I think as we looked at a predictive and a projection model worldwide, we would not be surprised if this number changes considerably. I know we feel like we're making really great strides, but with the variants, I think we get a little nervous. So, and I do put links in for most of my slides. Here you can see that most of you have already seen this. If you read any newspapers, if you're online at all, you're going to see lots of graphics like this that are going to talk about COVID deaths. I do think the industry of senior living, skilled nursing facilities has become a bit of a scapegoat, right? So a lot of it, because there have been such a high amount of deaths and people contracting COVID within the long-term care and assisted living sector, even adult daycares, I think that we've seen a lot of this come to light where many news articles and so forth talking about this. As of March 7th, as you can see, 174,000 plus deaths in senior living, and residents and patients that were affected is 1.3 million. I'd be interested to see what the data would be on the people who work in our long-term care facilities, and not just our nurses and physicians, but those that support long-term care. Over 33,000 facilities that have been impacted. So you're going to see a wide variety of these numbers. We could debate how the data is kept. I certainly think internally, I live in Connecticut, working for Yale New Haven, we keep copious amounts of data, and our state does as well. So we know where residents are coming from, what towns they're coming from, and most other states are really doing a lot with data as well and drill downs. So I would say, if anything, this is probably on the light side of counting rather than the heavy side. So again, we might be done with COVID. I'm certainly done. I'm very exhausted with having to wear my mask and socially distance from my family and friends. But I liked this graphic just because I do feel as if COVID came in, right, like a wrecking ball. So last year at this time, before COVID started, I was actually in Italy for a few weeks. Came back over on a plane. Didn't really realize the pandemic had started to take hold and people were so nervous. And I was with my 20-something daughter who coughed the entire flight over here. So I think for me, then life changed from then, right, from last February on, and hasn't gone back to normal. And certainly in my job, in the beginning, I would say through almost most of last year, was working 12 and 12 and 14-hour days. We are now looking at some good news, right? We're getting a bunch of our population vaccinated. I actually worked at our vaccination clinic this morning where we were vaccinating people with developmental delays. And so it was a really happy time. A lot of parents of this clientele were extremely happy to get their loved one vaccinated. We're seeing a decline in new cases in nursing homes. I think it was a great move to vaccinate our nursing home and assisted living and over 80-year-olds because it had the greatest impact. And now we're seeing that 65% decline in deaths at facilities. Bad news is, of course, we've got these variants that are more transmittable, and I think we're seeing a higher mortality. Vaccine hesitancy. So as we've opened up in my state on April 1st, it opened up for everyone. And I will say that there's still appointments available. So when I see appointments available, it makes me a little bit more nervous because I feel like that vaccine hesitancy in staff. I don't know if you saw that Italy and some other countries have made it had made vaccination mandatory. I think it'll be interesting to see some universities are starting to do that. I haven't seen the health systems. I would fully anticipate larger health systems in the country will make that mandatory, similar to the flu vaccine, and some states will as well. And again, the duration being 1 year, this is true. And I would say it'll be very interesting to see what they come out with for next year and moving forward, and how do we vaccinate children. I also think the long-term effects of COVID are still yet to become. We're going to be starting to open up our long hauler clinics. And we have a lot of young patients with significant cardiac issues related to having COVID. Many people recover from COVID and have no issues, but we're starting to see the impact of that long-term COVID. And here you can see Dr. Walensky, I know, got a lot of pushback on this about being scared. And I think that we all do need to realize that the CDC has data that we don't have. So what you're seeing in the news is probably just the tip of the iceberg. So when I'm on calls with the CDC or with my state health department or with any other regulatory body, some of what they have to say that the general public might not be aware of is very frightening. And I think the WHO, the World Health Organization, is working to that end as well. So we're not in Kansas anymore, right? I think that Dorothy, I think this analogy is pretty true, right? If Dorothy, we'll talk a little later on in the presentation about risk assessments, if maybe Dorothy's aunt had really been prepared for that tornado, right, she wouldn't have ended up in Oz and all that goes along with that. So I think for many of us, what we feel like is, were we prepared for a pandemic? I certainly feel as those of us in acute care, and I work in ambulatory long-term care, every sector, I feel like some sectors were certainly much more prepared than others for where we've been transplanted. And certainly our heroine Dorothy was able to navigate her way through Kansas. And so I think that some of us might want to look at that analogy a bit. The pandemic has really changed, I would say, the way that we think, right? And the way that we think about our lives. I think that it's important for everybody to think of all the different sectors. So if you're looking at your sector, and I always look, I like to travel. So for me, I always try to compare, that hospital experience. I think those of you that are in long-term care are going to think a little bit differently than assisted living, a little bit differently than other kinds of sectors but now our consumers are very sophisticated. So we have social media, we have different rating systems, we have the news. What is the most likely thing? Are people going to really look at the cruise lines now and say, what is cruise line A and B going to do to make my travel and my trips?
Donna, I think you may have been cutting off. Can you hear us? Donna, can you hear us? Oh, I think she's calling. There you go.
Oh.
Sorry, you got cut off, Donna, for a few seconds. You managed to just replay about 30 seconds back.
Okay. Was I talking about cruise ships
Yes.
or airlines, Raj?
Cruises.
Okay. I personally will not be taking a cruise, but I think that those that do cruise that I've talked to that are going on in the fall are starting to analyze what the requirements are going to be. And my understanding, it's going to be mandatory vaccination. So to get on that boat, you're going to have to be vaccinated. I fully anticipate that maybe we'll see some of that for international travel. I have a wedding in Italy next year. And for my international travel, I'm anticipating having to have some sort of vaccination. I think that there's a lot of controversy right now around this vaccination requirement or certificate, but I think for many years we've had to be vaccinated against different diseases. My kids all traveled abroad and studied abroad, and they couldn't go without certain vaccinations. People coming to this country have to have specific vaccinations, and certainly to work at my hospital, you have to have your hepatitis B vaccine. So I think that they were socializing it right now with the pandemic, but we're fully going to see this come about. When I go to hotels, that's one of the first questions I ask, because I still have travel for work and I do a bit of speaking, is to kind of talk a little bit about when I visit clients, when I have to stay at a hotel, what their cleaning practices are, and so forth. So I think that we're going to see our consumers really being very thoughtful about the way that they consume different services. So again, trust in senior care, right, and safety. And this is just looking at a percentage of respondents.
I'm sorry, Donna. Sorry to interrupt, Donna. Would you mind showing your screen?
Sure. Hold on. Hold on. Uh-oh. I think that what happened, Raj, was I got kicked off of the. Okay. Hold on one second. I'm gonna have to go do the share screen again. Okay. There.
Yep, there you go.
Can you see? Yep.
Yeah.
Okay. All right, great. Let me go backwards though. Okay. So here is the, again, trust in senior care. I think trust in a lot of things. I think, again, like we said, we're not in Kansas anymore, is for a lot of things, we're going to see our consumers be looking at things very differently than they are now. So here you can see, of course, the different generations. I'm sure a lot of you have already analyzed a lot of this data. Is where are people coming into this industry of long-term care? Who's doing the research, right? So again, very active on social media. I know if I want to try to find a recommendation for something, or Yelp or other things, certainly there's people out there, people, as you all know, are more likely to write a negative response than a positive response. I think we're going to see a whole generation coming in having a questioning attitude. We certainly see that in the hospital setting. So very different, have a lot of questions for us, very still hesitant. I think our emergency room numbers are still down. I know I've been seeing some studies in long-term care and assisted living. I think I have another slide that speaks to that, but really looking at what is that consumer trying to do to make that decision about using healthcare. At all. And I would say about maybe even changing their decision about where they live. You know, are people going to be likely to go into an assisted living setting or put their parent into an adult daycare or long-term care or rehab without having a lot more information now about the trust and trusting people with the quality and safety of their loved one. As you all know, the Centers for Medicare and Medicaid Services does provide this 5-star quality rating, and they are going to go back to measuring that. So if you take Medicare dollars, and I think that Medicare, in the conversations I've had with Medicare, I think we're going to see Medicare pay for many more things. I think we will see an expansion in Medicare and what Medicare pays for. And with what that comes with, right, is in January 27th, Medicare told hospitals, long-term care, acute care, rehab, ambulatory surgery centers, everyone, that with their health inspections, they would now resume their focus on quality and infection prevention. So I think those of us that have Medicare surveys are looking very closely at what that looks like. In addition, making sure that everybody wants to be getting this 5-star quality rating. Here you can see more than 1/3 of all U.S. nursing homes have an overall rating of only 1 or 2 stars, accounting for 30% of all nursing homes. I think, again, we debate all the time. There's so many different metrics for hospitals. We have Leapfrog, we have Joint Commission, we have HHHC, we had a magnet survey last week. Ambulatory care places have different ratings. I know that long-term care does. And so the question is, we can all debate again what the star ratings mean, what the quality metrics are. But I think when you're looking at the consumers are trying to look at something that's easily digestible. So they're really looking to try to find out colorful, fun graphs, right, that can be shared on social media. They can talk to their friends and family. They can go on the Medicare website, do a Medicare compare, and then put in different, for us, they can put in different hospitals and look at different quality metrics. I think that the hot place to be right now is public health. So you have kids going to college, kids looking at colleges, kids in high school. Public health is going to become the new hot job. So I think it's an interesting topic, and certainly if you have kids that are interested, or if you yourself are looking at another degree, public health is going to become something that we're all be looking at a lot more closely. So here you can just see some of the data that's out there. And I think for me, my mom happens to be 78. I have been looking at different assisted living aging in place, and a lot of new places near me in Connecticut. She currently lives in Rhode Island, and we're touring places in Rhode Island as well. I think being a nurse, I had other questions. So I had a lot of questions prior to probably COVID, more surrounding safety and falls and so forth. And I kind of put this slide up to say, for me as an infection preventionist, when I'm on the part of, let's just say, design and construction and textiles, I often will have architects, builders, CEOs, chief operating officers asking me about the environment of care and the design and the flow and the safety. I think the consumer, on the other hand, now is looking at this and saying, for the care and love and safety of my loved one, right, I want them to be able to socialize. And unfortunately, this pandemic has changed things so much. Like I said, people are looking at that cruise ship and having a questioning attitude. We're going to be doing the same thing when they're coming in and they're asking about the quality and safety that's being provided at where their loved one will now be aging in place. So I think it's really important to be able to address comprehensively those questions that the consumer is going to have, as well as I think we're going to see a very big shift in any insurance dollars you might take, or Medicare dollars, or even private pay. There's going to be a certain expectation about what a quality infection prevention program looks like. So how do you set up yourself apart? And the next part of the topics, I think, Raj, you have our next slide. I'll be talking about that. But I think how you set yourself apart for infection prevention, for me anyways, is when I go in and survey a facility, is I like to be able to talk to the person on the ground, that infection prevention liaison, who can really have a crucial conversation about their thoughtful process. So what have they done for a risk assessment? How did they evaluate what the risks were to the client that is coming in either for surgery, to the person that's coming to live in the assisted living, to the skilled nursing facility who maybe is having a higher acuity of care? So I really like to have a point person that's there that can speak to the kind of ongoing education. Lots of the studies that we see in a hospital setting is you can educate somebody 1 month, that's physicians, that's nurses, nurses aides, dietary aides, and the next month and every month after and every week after, they can lose 10% of what you've educated them on before. So whether that be concerning personal protective equipment, cleaning of equipment, and any other metrics that you have, it's very difficult to maintain that level of competency that you really need. So when I go in and take a look, I really like to see a really good program plan and risk assessment that's well thought out and has been looked at every year and updated every year. And Ross, I think this is your slide. Oh,
sure. Yeah, absolutely. Thanks, Donna. And by the way, Donna, on that forgetting curve, I actually did some work. There's a very famous, I think he was a professor, his name was Ebbinghaus, and he did something called a forgetting curve. And the idea was, how much do you forget over time? And if you just think back to 2 weeks ago today, and think back 2 weeks ago, what did you have for lunch? You probably don't remember. And even in training, that's the case. They say something like 80% of what you train on is lost within 2 weeks. all the details,
Yep.
et cetera. So it's the core part that matters. The details get lost all the time. So you've got to continuously reinforce the training related to that. It's called the Ebbinghaus curve for the folks who want to hear about it. And it's called the forgetting curve. What I wanted to chat about here, just sort of, if you think about the spectrum from hotels that Donna talked about and just being careful about what the hotels do, all the way to the spectrum down to the hospitals to the right. Just think about pre-COVID and imagine these dials, the blue dials. If a pre-COVID from an IPC program, you have to be at a level 2 for a hotel, and a level 4 for senior living, and a level 6 for SNFs, and a level 8 for hospitals. Essentially what we've had to do is shift left. What I mean by that is in post-COVID, go forward way, even hotels have to think about their infection control programs, right? Their cleaning mechanisms and all the solvents and everything they do to sanitize the room, much more, probably 2 times more than what they did, before that. Same thing goes now for assisted living, memory care, senior living in general. We've had to ramp up and bump up and accelerate our whole IPC program to a level of 6. If you're skilled nursing, if you were originally, let's say at a 6 on a scale of 1 to 10, now you're at an 8. And then for a hospital, if you're at a point of 8, and by the way, I don't know how old folks are on the call here, but if you remember the movie, This is Spinal Tap, and remember the guy, he had that amp and it was turned all the way up to 11. Essentially, that's what hospitals have had to do, is they had to turn up their IPC dial, if you will, all the way up to 11. So mentally, this is a really important concept just to kind of make sure you're like thinking about, as an IPC program, everything has shifted left in a way that it's got to be much more aggressive and much more structured and much more thoughtful than it ever had to be for everybody across the spectrum, from hotels to hospitals. Donna?
Yep. Thank you. And I agree with you, Raj. I think this is a great slide in stating that. I think that for hospitals, we don't see the same amount of healthcare acquired COVID. So we just have general regular practices, and we've been dealing with tuberculosis, measles, airborne illnesses for years, for 50 years. So we already had practices and protocols in place. So I would say moving forward, really what we're gonna be looking at for senior living and SNFs is the expectation is that your program should be completely up to speed now and moving forward, because next winter we will see more COVID, that there shouldn't be transmission of COVID within your facility. And there certainly shouldn't be deaths related to COVID. I think I was surprised that we still did see gaps this last January and February at long-term cares throughout the country, because I felt like people had a good 8 months. But to your point, getting that dial turned up 2 or 3 degrees is a big lift for most places. And we'll talk about some of those challenges going forward. Go ahead, Raj.
Sure. So I thought it'd be good to just kind of share with you all some lessons I've learned from working in other sectors related to the whole regulatory scrutiny that's about to enjoyed us over the next few years, I think. If you recall last year, I was talking to a very senior advisor of ours who's in the industry, and he said, look, the senior living industry has gone to Congress and said to Congress, hey, we have a lot of needs in terms of who we're taking care of. The folks that are in our facilities in assisted living memory care are having the same challenges that maybe a SNF might have. And so we need additional COVID funding related to the COVID acts that happened over the last 2 years. So Congress actually has given billions of dollars, right, to these senior living and assisted living community, all the different communities here. At the same time, when Congress gives, they also want something in return. And what we've essentially done, he said, was open the eyes of Congress. And so what we can expect is a lot more regulatory scrutiny going forward. Donna, you just said a minute ago that, we've got to turn that dial, because what may have been okay in the beginning of the pandemic in February, March, April, would not be okay later in the year, and it'll definitely not be okay next year, right, in terms of the response that the industry's had. And this is a good segue to the food industry. If y'all recall, about 10, 12, 15 years ago, there were a lot of issues with food recalls and sicknesses from E. coli, salmonella. Essentially, it's a pathogen, just like COVID is, and it was infecting and affecting our entire nation's food supply, right? Every consumer was affected by it. We had these salmonella outbreaks in beef, cantaloupes, lettuce, chicken, etc. So Congress passed the Food Safety Modernization Act in 2011. And what that act did essentially was give the FDA and USDA a whole lot more enforcement powers, new regulations and new fines, to the point where they could actually shut down an entire processing plant in food if they found some inspection issues. So in response to that, the whole industry, the food industry, had to totally upgrade their training of their frontline workers, become audit ready, because the auditors from the FDA and USDA could just show up at any time they chose to. It was all surprise audits. And they invested in the technologies to make sure all the food systems were in good shape, everything from X-ray scanners to make sure foreign materials weren't in, much higher levels of testing of the food itself before it was shipped out, things like that. And they built a continuous and sustained improvement process for food safety, to the point where food safety is now just one of the most safest things you can think about. And when you think about, we have about 330 million people in the US. Each of us eats at least 3, in my case, maybe 4 or 5 meals a day, especially with COVID. So about 1.2 billion to 1.5 billion meals that everyone is eating on a daily basis. And just think about how many issues we're having with E. coli or salmonella. In the big scheme of things, of 1.2 billion meals per day, it's almost minuscule, right? So that's an example of what's happened in the food industry, how it had to react to all the outbreaks that were happening with E. coli and salmonella, how the government got involved, and then now how the industry itself has had to make all the changes, but not just for the government's sake, of course, but for consumers demanding it as well from a safety perspective. Donna?
Great. And so many of you who are in the long-term care sector will be familiar with this from NHSN, which is the National Health Safety Network. So all hospitals, we give a considerable amount of data to NHSN so that they can monitor. So every month I report infections at my hospital. I infer catheter or associated infections, all different other kinds of metrics. And I would say here is I just took a screenshot of the long-term care module for COVID-19. There's actually 5 surveillance pathways for NHSN. To Raj's point is we're really looking at, there's already a computer program, there's already a platform that's going to have an expectation for data to be inputted. The question is, how do we abstract that data and ensure that we're giving the correct data to the federal government? Many of you might have an EMR, you might have an easy way to do this, but I would only expect this to be, like you said, from the government standpoint as well as the consumer standpoint, for this to expand. And quite frankly, it's the right thing for the patient, right? Or the right thing for the resident. I think looking at that impact, so looking at your admissions, your newly positive tests, and I think this will expand. It is not going to be just COVID. What else might that senior with a very fragile immune system have when they come in? What kind of test type? What's their vaccination status? Reinfection, deaths, influenza, respiratory illness, that's other respiratory illnesses, which we used to see. If people came from a long-term care facility, we were already always on alert that they might have some sort of multiple drug resistant organism or infection. It was very common. I don't think that's going to be acceptable any longer. Any kind of co-infections, viral testing resources. They're going to want to know about your staff and personnel. This is a very, very hot topic. And we're also seeing many of my centers I consult for are seeing staff and personnel actually bring litigation against their employer for exposing them. So I think we're going to see this now. If the employee gets a needle stick, if the employee is exposed to COVID, if the employee is exposed to any other disease, what might that employee now feel like their personal rights are? Looking at those PPE supplies and supply chain, right? All of that changed very much. I know many of you had a hard time getting some of the supplies that you needed, including cleaning supplies last year. Ventilator capacity, and of course, therapeutics. Okay, so looking at all of that and how the residents are checked. I think this is a great slide to kind of talk a little bit about what the operations are and how you've had to change everything that you've done. I think, kudos to every healthcare organization, any organization. Like I said, you can go all the way from cruise ships and travel to those of us that serve a population that it might be immunocompromised. So again, all the visitor restrictions and the impact that had on your residents and on your family, and even residents being able to visit with each others. The screening, how do you operationalize that? Giving tours to people who might want to come into the facility. Move-ins, a lot of you had suspended move-ins. Daily screening of staff for COVID symptoms. I know there was a lot of current controversy about this around the country about whether or not you could actually screen your staff. daily screening of residents, communal dining rooms being closed, more frequent communication with residents and family members, videos, video chats, and all the communication. I mean, how do you all of a sudden create an infrastructure that can change all these operations, and more frequently disinfection of surfaces? And this is just to name a few. All of you out there really know of all those other operation changes, and I bet that if I had you make a list, it would be 3 or 4 times longer than this, of all the things that you had to change immediately throughout this pandemic. And I would really question to say that I don't think anything is going to change back. And if anything, things are going to be made permanent, and more infrastructure is going to have to be created. Here's just a great infographic that kind of speaks a little bit to all the changes that happened and how quickly. So at this point back in February, I was having, almost weekly webinars with my clients to call in just like this and go over what all the new changes were. There were so many. And starting in July, of course, here's the announcement of quality improvement organizations to assist facilities in hotspots. I don't want to be the bearer of bad news, but I fully anticipate next winter we could potentially see additional cases. I think we're going to get to a point where, right now, if we average 1,000 deaths a day and thousands of cases a day, we all become kind of immune and numb to the numbers. I think when we start looking at July 2021 and February 2021, and we can start going into 2022, we're not going to be numb anymore. The expectation is going to be that any outlier is an exception and unacceptable. So although there could be in every state, let's just say, double-digit deaths in long-term care assisted living and in the population over the age of 80, I think by 2021, that's not going to be acceptable to even have one death. That's going to be considered a never event, like a plane crash. I mean, right now, there's more deaths per day. Sometimes there are more deaths per day than 9/11. So I think right now we're numb, but that's going to change considerably in 2021. I'll talk a little bit about the rate of injury and illness. And so here you can see how much that has changed. It's become 2 to 6 times higher. And these are non-fatal injuries, and some of them are going to be back injuries. For acute care hospitals, employees can put in an exposure report, which is considered a potential injury. And certainly that has to be investigated. So certainly if you have employees who think that they've been exposed to COVID and contracted COVID while at work, that becomes a workman's comp claim. And I know a lot of you have probably had to deal with that throughout the pandemic. So even if you are an acute care skilled nursing facility caring for patients that are bedbound and that maybe have respiratory symptoms and have many licensed staff, all the way to when I was interviewing just the age in place patients for my mom, they said, we can send somebody in just to check in on your mom 15 minutes a day. Well, I'd want to kind of know a little information about that too, as far as the screening of that employee that might be only spending 5 or 10 minutes, the person who's running the swimming class or the aerobics class or the yoga class or giving golf lessons. I think it's going to make people have a questioning attitude about everybody, their exposure, and it's going to make your staff members also be very astute into the possible exposures they're going to have at work. So again, this is, I'm not going to read through this slide, but Nick Dykes Senior Living kind of talks a little bit about worker safety, calling about greater enforcement for OSHA. I think I had not really dealt with OSHA for many years, and I think now throughout the pandemic, many of the people I consult for have had staff members call with an OSHA complaint, and then had OSHA come in and say, well, exactly what are you doing to protect your employees from these respiratory illnesses and any other illnesses that they might be exposed to.
By the way, Donna, the numbers you were showing, the 6.1 injury rates, that was actually 2018 data, I believe. So this is pre-COVID.
Oh, wow.
Yeah,
Okay.
the pre-COVID data that shows that how dangerous, frankly, from an injury point of view, it is to be working in a senior care industry in general. And so twice as more dangerous, for example, than coal mining construction. My expectation is that 6.1 will go higher because of what you just mentioned, which is if they can report respiratory illnesses as part of this and things like that, this number might actually trend upwards in the coming years. This is a 2018 data, I believe.
Okay, so yeah, this doesn't even include all of the persons who work and might potentially want to call OSHA because they feel like they've been exposed because of maybe a lack in a respiratory protection program. So if you have not done a respiratory protection program, I actually feel like this is great for hospitals, but certainly the long-term care sector should have been doing this. And if they had been doing this for the last 10 years, I think we would have seen many less cases of COVID, because a comprehensive respiratory protection program, OSHA has it right on their website. This is sponsored by the CDC and NIOSH. And again, I have a link to this, is spending a good amount of time. I would say when we're looking at that ICP role, they should be spending at least 3 or 4 hours a year reviewing the respiratory protection program kit, make sure they're maintaining the respiratory protection program, and then implementing the respiratory protection program. And that's really for all levels of acuity. I feel like nowadays I have a respiratory protection program at my own house. So we had people for Easter and we're all vaccinated, but I feel like I was kind of like, okay, who's going to wear a mask? How close is everybody going to be to one another? And so I feel like I have my own internal respiratory protection program at this point. In addition, part of what the role for the infection prevention person, boots on the ground, is going to be that water management plan. And for some of you that live all around the country, it's going to be very different in Texas than it's going to be in Washington State, than it's going to be in Connecticut. And this is in the prevention of Legionella, and not Legionella for only your residents, but Legionella for your employees as well. So if I don't know if you remember, many of you years ago, it's named after Legionnaire's disease, which happened to a group of Legionnaires back, I think it was in the 70s. So now we really look at this. The CDC has a great 36-page guide to stopping the spread of Legionella in a building. And it has a questionnaire. You can't really see it here, but there's a questionnaire here. The first question is, do you care for patients with any immunocompromised system? And I would say if anybody at your center is over the age of 55, all of us have a declining immune system. I'm almost 55 this year. And so, yes, you do. I've really debated this with many of my clients about whether or not they have to do this Legionella water risk management plan. And 100%, I think it's the right thing to do. OSHA also has this if you haven't seen this, then you know you need to get on that OSHA website and you need to make sure that your program plan is updated, because this is that's the hierarchy of controls. This is a very famous, it's been around for a long time. OSHA talks about what is the most effective thing to eliminate, and this is injury. You can use it, I use it for respiratory, right, or infection prevention or quality and safety, but it can be used in any industry. So physically removing the hazard is the best thing you could do, the most effective thing, right? But we can't remove COVID. I mean, maybe someday, but I think we're years away from that. It's not applicable for COVID, but there's substitution of replacing the hazard. Engineering controls, so it's like isolating people from the hazard, right? Administrative controls, changing the way we work. So I haven't eaten lunch with somebody at my work in over a year, and I still would not eat at work with somebody in a lunchroom. And then the least effective, but probably what most of our clients as well as our staff members want, is PPE, right? And when I show this slide and I do all my training with people, clients and people that work for me, is they all want the PPE. It's actually the least effective in the hierarchy of controls, which I think that most people don't think about. Everybody thinks that the N95 is going to solve their problems, but it's actually not. So staffing and empowering that IC lead role. Okay, so every organization is going to have to make your own plan for staffing depending on your unique circumstances, size, residential profile, state, and local mandates. I will say that APIC, my national organization, does have one for hospitals and hospital beds. I have been a proponent for the last 10 years in my work with long-term cares that this has to be a designated registered nurse or LPN. Especially if you have over 20 residents living in your facility. If you have any, Foley catheters, if you have any feeding tubes, anything like that, then you really need to have a designated person. And that doesn't mean a person who's also a charge nurse. And this is going to be the challenge, right? Is If there's anything like getting nurses to retire, there's nothing like a pandemic. So really looking at your own program plan, evaluating your staff, and seeing who might have that interest in infection prevention. Three things to be successful.
Donna, quick question. Donna, I'm just curious. Yep. Like, I know you like turning that dial to 11. We talked about in a hospital setting. Can you just, for the audience, just kind of give a sense of what a hospital system is doing from an infection preventionist point of view? Just give a little scale of the Yale New Haven operation, because it's not just a single hospital, right? It's a whole bunch of facilities. If you just give a background, not that assisted living or skilled nursing would have to do anything near what Yale New Haven does, but just give a sense of what the extreme number 11 looks like versus a number 5.
Right, sure. So in hospital beds, it's usually one infection preventionist for every 150 to 200 beds. So we're a 5-hospital system, and we have 11 infection preventionists. When I first started 13 years ago, we had 3 of us, and that's in 13 years. That's how much that's changed. When I'm on national calls, and I've sat on the board for my education board for my national organization, we have given many seminars for long-term care, and most long-term care, and this is going back 10 years ago, would maybe have somebody who spent a few hours sometimes. Now it's becoming much more specialized. So many of you, some of you on this call, are working in long-term care and are certified in infection prevention for long-term care. It is a very, very difficult thing to find somebody who's competent and can meet the challenges that are unique to long-term care and the risks that are associated with it. But I would say, I think that APIC probably does have some sort of mandate to this, a number of hours that need to be spent. But hospital systems are going. My hospital is 250 beds, and we have 2 full-time infection preventionists and a team of analysts that does all of our surveillance for us. So I have another 3 people that support me for my data analytics, and data to submit to the federal government. So I mean, I'm working with 5 people for 200 beds, which I feel very lucky, very, very lucky. Many smaller hospitals, I have clients in Wisconsin, I have clients down in South Carolina, and many of them really have a challenge in being able to staff for infection prevention. It's a hard thing to stay up on all the knowledge and training. I consume a lot of, I'm up sometimes until 9 or 10 o'clock reading new guidance, reading new CDC guidance, reading new studies that came out. There's a bunch of really interesting new studies that have come out recently about the vaccine and about infectivity, about the new variants. So a lot of that we're taking a look at. They have to have the authority to carry out the infection prevention program. So this can't be somebody who doesn't have a clinical background. There's not really, there's too many clinical decisions that have to be made about this. So it has to be, in my mind, a licensed person, and then have the resources to manage the program, the time and the tools, know which websites to be going to, which guidance to read. And this is just an infographic that's put out. Here's APIC, and if I give you the link in there, that's the Association for Professionals in Infection Control. And they have a whole membership section and certification for long-term care. I know a few other people have certifications for long-term care as well. This is going to really tell you how I spend my time. So I think that, again, surveillance and investigation. So in a larger long-term care facility, looking at the surveillance has become the cornerstone now, right? How do you identify who the index patient is that maybe got an infectious disease, and now 2 or 3 other residents or staff members have that infectious disease? Prevention and control of transmission is going to be about another 15 to 20%. And I would say that is looking at that day-to-day EOC. So walking around every day, doing audits, talking to staff members, talking to residents, and talking to family members about how to prevent and control the transmission of infection. Identification of infection. So any staff members who are coming to them and saying, hey, I think that I'm sick, I have this, or a resident that's saying that. Management and communication, so lots of communication, emails, coming up with best practices, doing in-services, education. I'd like a great education board. I have like a 40-page guide I give people that have all kinds of printables, so they can print them and then huddle on them every month. So to your point, Raj, when you were talking about that constant continuity, answering questions, and how much the education has fallen off, it's so important to really stay on it with every huddle every week. the environment and how clean the environment is, cleaning and sterilization, and this is more for instruments and things like that. And many of you might not have that. And then employee and occupational health. About 2/3 of IPs work in acute care hospitals, but the other third work in long-term care, outpatient facilities, ambulatory care, and other settings. Only 43% are certified in infection control and prevention. I will tell you the state of Connecticut has just passed a new law, and I think we're going to see this around the country, mandating long-term care to have a designated person and certain qualifications for that person, okay? So 38% of infection preventionists plan on getting certified in the near future, and there is some specifics to that. And I think we're going to see more of it. I can't see a world where we're not going to have new organizations offering certifications in CEUs for infection prevention and long-term care. I think it's obviously come under a microscope and scrutiny.
Donna, I can give you an example of that in the food industry. The mandate became every processing plant in the food industry had to have a PCQI, which is equal to the CIC. It's preventative controls qualified individual. You had to have at least one always on duty when the plant was running. So many plants had to have 2 or 3 of these folks certified to be able to do that. It's a 20-hour course to get certified in an exam and renewal exams.
Wow.
And things like that. So you're absolutely right. Like it'll start happening in the coming years for sure.
Right. I think that, and again, I think it's the right thing to do. When I talk to my clients, I tell them, I know people we all can have a lot of thoughts about regulation and guidelines, but to your point, right, it's consumers as well, and what's the right thing to do. So, the food industry had to step up, right, because nobody wants to go to the grocery store and think they're going to die from eating a piece of chicken that night, or their child's going to die. We do a lot of foodborne illnesses, and a lot of people get hospitalized annually. We track that and we report that to the federal government. We report everything to many diseases. I have a guy with malaria, you're going to report that, and where did they get malaria? Did they get it in Connecticut? Did they get it out of the country? So we're always watching all diseases. I think that's why that comprehensive risk assessment and program plan is important. Like I said, there's going to be different risks in long-term care, maybe in a rural section of Texas, Colorado, Utah, than in a more suburban setting, maybe here in Connecticut, and then maybe we're looking at New York City, and they're going to have different challenges, right? So I think that looking at that comprehensive annual risk assessment and program plan, changing it every year and having it approved by a board of directors is very important. It should be detailed and very specific. And I go back, I know it's simplifying it, but if I'm going to go on a cruise ship, I want a detailed, very specific program plan of what they're going to do to make sure I'm safe when I'm on that cruise ship. Forever, we've always had foodborne illnesses on cruise ships. So we get a lot of people who come off of cruise ships with, those kinds of GI bugs that can set you into the hospital for days. And so that's personally why I don't go on cruise ships, but now we have COVID, right? So because those are so highly transmittable. If you're going to go to the casino, anytime you touch anything, that's really going to be a problem. So very specific to your setting of long-term care, memory care, adult day care, or assisted living, all need to evaluate those risks annually. Now, I would contend that if that had been getting done for the last 10 years, and many of you did that, so I don't want to assume anybody didn't do that, that we would have had we could have had less deaths. And so I think moving forward, you're going to see that there will be additional templates and help from the federal government to try to help people to do this comprehensive risk assessment that we've done. Mine is 20 something pages long in the hospital. My ambulatory care centers, typically it's 2 to 5 pages. And I would say in long-term care, that risk assessment is going to maybe be 2 to 3 pages with a comprehensive program plan of what your goals are for the next year. What are the goals in 2021?
Yeah, Donna, exactly. One of the things we recommend is actually every 3 months, quarterly, to do the assessments, or the COVID-19 assessments for skilled nursing from the ones that we built as CareSafely is 79 different risk factors. So it's pretty comprehensive. So you're right. It's like, but I don't think it's even annual. It's much more quarterly right now, and then maybe eventually from semi-annual and eventually annually. But right now things are changing so fast that if you did an assessment for COVID or last year, there wasn't one really, right, last February. So our recommendations are typically much more frequently right now anyway for COVID specifically. But environmental care and things like that, probably more on a semi-annual or quarterly basis instead of the annual. I think annual is it's just too long a time period. Things are changing too much to wait for that part.
Right, right. And I think that doing that initial risk assessment and program plan in January,
Yes.
I usually finish it up in December, kind of looking at that year forward,
Yep.
having it approved. And to your point, then monthly, really going through it and making sure there's nothing to add or subtract to your program plan. But every year in that January, getting a really comprehensive one reviewed and then updating it. I completely agree. And again, these are some of the strategies that we look at, and these are all that can be included in a program plan. And then we look at risk assessment. You know, what is the risk that maybe employees are not going to perform hand hygiene all the times that they're supposed to? What is the risk that the environment might become contaminated and transmit disease? What are the risks of screening and cohorting patients together? We know that was a huge risk in long-term care in 2020. Surveillance. What kind of surveillance is going on? What kind of testing is going on? I know many of you are testing weekly now, and you know, with maybe the antigen test, but what does that look like moving forward? Antibiotic stewardship, I think, hot topic in some long-term care sectors in the prevention of C. diff. Following all kinds of guidelines, right? So that's another strategy. But what guidelines should we be following, and what kind of guidelines are changing? So I think we can see a lot of things in the news, and sometimes I really have to stop my centers to say, like, don't follow or chase that butterfly. Let's look at what the guideline was. There's nothing to change right now. A lot of centers went to cleaning and over cleaning. There was no reason to clean every single surface all the time. So really looking at the good quality studies and guidelines. And then overall, anybody who's done any Six Sigma or IHI training, it's creating that safety culture where people feel like they can go to the CEO, they can go to their nursing supervisor and say, hey, you know what, I saw this gap or I saw this missed opportunity, and I'm wondering whether or not we can do something about it. So I think creating that culture of safety so that everybody feels empowered to report things they feel like might not be safe. This is just one thing, the ingredients for successful cleaning and disinfection of, I'm going to say, like the environment or durable medical equipment. So maybe it's the patient's bed, it's a side table, it's a wheelchair, it's the tables in the lunchroom people are eating, it's the craft room, it's the gym, it's the art studio, whatever it might be, right? This is just one section. So this is why it becomes time consuming for the infection prevention lead. They have to have real clear specific things, right? Based on what the risk is. They have good, effective annual training, if not, like you said, Raj, more monthly training. Documented in the line of accountability. Who's accountable? Who's accountable when we bring residents from one section to the other, or from one place to the other, and making sure that somebody's accountable to ensure that the environment is safe and the client is safe. Involving the patients. So nowadays, we actively ask patients to tell us if their doctor did not wash their hands, and let the doctor know. So we give out handouts that say, if your provider does not perform hand hygiene before touching you, please remind them. We want you to remind us, we're all busy. All staff recognizing their responsibilities, audits to drive improvement, closing range with infection. So really looking with infection prevention and infection prevention and control, nursing leadership being engaged, and having board level support. And this is adapted from that National Patient Safety Agency back in 2007. So like I said, this is like my bread and butter from when I started in infection prevention, but I think sometimes there's a lot of catch up to do in some other sectors. Again, you don't have to really understand these slides, but just know that infection prevention can be a really comprehensive, difficult thing to monitor all the time. So I recently have been looking at the weekly deaths above normal, which in the country, we're looking at about 21%. So, you know, what we say is like, who normally at this time in March would, you know, what was the normal death rate last year compared to this year? And we're still seeing about 21%. So, you know, COVID deaths, we can all debate again on how they're reported, but did you not go for your mammogram? Did you not go into the emergency room because you had chest pain? You know, there's a whole host of other sort of secondary deaths to COVID-19. But I think overall with those ones where the patient comes in acute respiratory distress and dies or ends up on a ventilator, we really say it's COVID. Right now, we're still looking at about 20%. Percent of patients with a MRSA diagnosis, I just kind of stuck this in there because many of you are going to be familiar with MRSA and assisted living adult daycare. MRSA, kids who are in high school who do wrestling have a chance of MRSA. So again, not monitoring this that closely just yet. I could anticipate that these multiple drug resistant organisms will be monitored more quickly and more intense after COVID is over. So people can become septic from this, they can get pneumonia, they can get cellulitis and skin ulcers, and they can have complications in their medical care. So, this is something that we look at all the time, that community acquired MRSA. So if somebody comes into my hospital from a sniff and they end up with a surgical site infection related to MRSA, we're always going to kind of relate it back maybe to that quote unquote congregate setting. Again, I'm not going to read through this, but this is just the education series through APIC, which is kind of talking a little bit about long-term care and getting, CEUs, because there's a lot of changes with CMS and their mega role. And this, I think, maybe wasn't taken out, sorry, because you did already have that, but monitoring your infection prevention program management. Raj, do you want to speak to this slide?
Sure. Actually, we're going to be running out of time, Donna, because we only got a few more minutes. So why don't we just skip to a few more slides down?
Okay.
Just a high level Q&A.
I'm on Q&A. Yep.
Just go back one slide. And just to put folks on the here, I know we're running out of time, so if you have any questions, just go ahead and put it into the Q&A section. Just at a high level in terms of modernizing the IPC plan. One was, of course, dialing that up from, if you're at 4, you got to turn to 6. If you're at 6, you got to turn it to 8. That's clearly the sort of the overall message I got from listening to Donna, and she's at the extreme 11 end of all of that. The second part of this is a continuous improvement. That's the key takeaway I took. It's like, this is not a one and done. We just got to get through COVID and somehow it'll magically disappear. This is a long-term continued improvement approach that one has to take. It's not something that'll just go away, because there'll be other issues that will come up. There'll be more regulatory scrutiny and other scrutiny that's coming up. And the last part I just wanted to mention is more of a shameless plug, I guess, about CareSafely. But if you think about all the things that one has to do related to infection control and safety and quality, if you're using spreadsheets and paper-based assessments and emails to chase people down to do action plans and corrective actions, if you're doing all those things in a manual process, you may want to consider something that's much more an automated workflow that makes this whole process a lot easier. The example I'll give you is the COVID-19 assessments for skilled nursing or assisted living. We've actually gathered all the information from CDC, CMS, and all the different state public health departments. And it ended up being, we have a 79 question assessment just for COVID-19 for those kinds of facilities. Most folks I talk to, they say they either don't know the answer or they'll think, oh, we do about 20 or 30 different questions related to our assessment. So anyway, if you're interested, we'd be happy to have a conversation with you about CareSafely and how we help manage that entire process. So with that, Kate, we're going to turn it back to you. I know we're running out short on time, but for Q&A.
Yes, so we have a few minutes for Q&A. Thank you so much, Donna and Raj. First question, would you recommend having other clinical personnel involved in the risk assessment, and if so, who? This is for Donna.
Right. I would definitely recommend having your medical director involved. I deal with a few medical directors in long-term care in Connecticut, and so I get phone calls all the time from them. I'm quite good friends with a few of them who have questions about that isolation. So I think a physician is a good one to have on board. And then somebody from nursing, and certainly it can be multidisciplinary. So if you have a great manager that for your environmental services or anyone else, you can make it multidisciplinary, but pretty much I would say working with that medical director and the director of nursing, and then whoever the liaison is. In some of the long-term cares, quite frequently I see that it's the director of nursing that also takes on the infection prevention role.
And Donna, one more. Someone asked if you have your basic guide available that you had talked about during the presentation. Do you have that?
Sure, yeah,
it's on your website.
I do have, it's geared towards ambulatory, but sure, why don't we get somebody's contact information? It wouldn't be on the website because I have actually, outside of my website is just, advertisement for myself, and then I have a back portal for clients, but certainly get the person's contact information.
Okay, perfect.
Yep.
And Raj, for you, does the CareSafely platform include infection control elements and assessments? You touched on this a little bit with the number of assessments involved. Is there anything else that you could tell this person about the platform?
Yeah, so it's a software platform, but you also provide all the pre-built content, meaning the assessments and the audits. So we have assessments for every type of senior care facility, for COVID-19, for MRSA, for C. diff, environment of care. So it's about 25 different assessments that are pre-built. But one of the cool things we do is we enable our clients to actually take our assessment and clone it and then make it their own, meaning they can add questions, take questions out. so they can make it exactly fit their specific organization, depending on what their the profile is, where they're located, et cetera. So it's that the flexibility to configure it to their specific needs. Same thing with staff competency audits. We've got about a dozen different staff competencies. Our research shows that if you hire somebody and then just put them on the floor for on-the-job training, it's about a 68% compliance to the safety standard, infection control standard. If you do really good training, you get 82% compliance. But if you do 3 staff observations in the first 2 months of their employment, you get 94% compliance. So we recommend don't just do once a year staff competency checks. And that's all great for your 5-star ratings and things like that. But if you've got a system where you can very quickly do hand hygiene observations, med pass observations in a very quick way, you can get compliance all the way up to 94% with just 3 quick observations. So that's the way we think about it, is much more, not just cross-disciplinary, but just more broader approach to it rather than just patient or resident focus. It's everything around it, including things like dining assessments.
And how I'm going to be using it as a consultant, I know some people that were signed up for the conference were also a consultant, was to individualize it for each one of my clients. And then what I like about it is that then you can turn around and say, Mary at, New York City Surgery Center identified on a visit that I went to that the instrument room was cluttered. I can tag her, and then the follow-up will be designated to her. So I do like that part of it, is having a stakeholder who now has to own whatever the deficit might have been. So I think that's important.
Accountability, right, Donna?
Yeah, absolutely.
And speaking to that, we have another question. Do you think assisted livings will be required to have more nurses? Raja talked about this a little bit with with Congress giving more money, having greater expectations. Do you think assisted livings going forward, post-pandemic even, will be required to have more nurses on staff for potentially residents with a little bit of a greater acuity?
I don't know if you want to speak to this. I definitely think I follow this nationally. I think, staffing ratios and things like that. I would only anticipate, and like we said, who's aging up? I'm the one aging up. In 10 years, I'm going to be your client. Maybe with the way the pandemic's been going, I'm going to be your client next year, because I feel like I'm beginning to really need to have somebody take care of me every day. But anyways, is I feel as if absolutely is the consumer is going to say, what does good quality care look like, right? If there's one fall in assisted living, they're going to say, well, what did you do to prevent that? Or somebody took their meds the incorrect way. So I can only see where as the acuity changes, absolutely. And the only way to evaluate that is through that good risk assessment and then that ongoing quality care. I tell clients all the time, I'm here to keep you out of the courtroom as well, because I feel as if people can go back 5 years from now and say like, oh, I never thought about that, but maybe that's why that happened. It's because, there really wasn't, they didn't have a good quality program. They didn't really watch out for that. They expect us to all know everything in healthcare, right? And be able to anticipate every hospital, and many of you might even be in the midst of litigation, because employees expect us to evaluate all risk and prevent any kind of harm to them. And I would say the same thing about assisted living, memory care, anything. Is that consumer is saying, and the price tag is not inexpensive. So if I'm paying $4,000 a month, if I'm paying $2,000 a month, my expectations are high. So it's just like the cruise ship. If I take a cruise ship and it's a $10,000 cruise, I better be getting a filet mignon every night for dinner. If I take a cruise ship and only cost me $500, I might let you, serve me chicken fingers instead. So I think that, I don't know why I keep going back to the cruise ships. I feel like it's because I really don't like cruises, right? So I'm using them as a scapegoat. It's terrible, isn't it? But
either way, Donna, I think it's an interesting point you made. You may want filet mignon for $10,000 and just chicken fingers, but you want safety regardless. Safety is not non-negotiable, right?
Right. It's
a non-negotiable. You're not going to want to get sick no matter what kind of ship you're on.
Right. And I think that this has torn off the Band-Aid of assisted living and long-term care. Yeah. So I think everybody was going along their way. And now when I talk to CEOs and managers and people who are working in long-term care, the stress and struggle and the no sleep and the, I mean, these are wonderful people. I have a weekly call and they are stressed because families are really demanding answers. They're demanding answers of why there's been an outbreak maybe of COVID. Now they're trying to look at every other thing, right? Or they've heard about, even if your center doesn't have a problem, they've heard about a friend's center out in California where 3 residents died of COVID, or somebody got sick, or 3 people fell last week. Everybody starts to talk to each other. And I think not being able to see that family member is very difficult. So I 100% anticipate there being some regulations surrounding staff ratios and expectations of licensed care within the facility, 100%.
Donna, thank you so much. That's going to wrap it up for us with the Q&A. If you have other questions, you can feel free to email me at kate.wallace@caresafely.com and I can forward them on to Donna. Also, there's Donna's email right there, as well as Raj's. As soon as you log off, you'll have a survey pop up, and it really helps us if you could fill that out, give us some insight into how you like the webinar, and give us some other topic ideas that you'd like to hear about going forward. Thank you so much for all your hard work. We know that it's been a very challenging year and keeping everyone safe and healthy. So thanks for your hard work and continue to stay safe. We'll see you next time.
Bye, everyone.
Thanks for coming.
Thank you.